Symposium. Moving on, I would like to invite our respected principal sir, Professor Dr. Jayanta Bhattacharya, to kindly address the gathering with his welcome speech.
So, a very good morning, ladies and gentlemen. It is indeed a very proud moment to welcome our esteemed guests for this morning, Dr. Saidul Islam and Dr. Asif Ahmed, who have responded to my personal request to be present here as the esteemed speaker. Welcoming you, both of you, to our college. I think you have visited this institution previously, but in your capacity as the esteemed speaker of our institution, it is indeed a proud moment to welcome you on behalf of JIS Group, all my faculty members, students who have assembled here. Dr. Saidul Islam has already been introduced, and if anyone has followed dentistry in the landscape of West Bengal would be knowing his name. As an undergraduate, 1987 to 1991, during my period at RMA Dental College, we have followed Dr. Saidul Islam and try to find out what sort of latest surgeries he was doing, even though at that point of time, Dr. Saidul Islam had not completed his master's. So it was a sort of inspiration for all of us to see that where you can lead if you have an interest in oral surgery, just by simple sheer determination, the level to which he achieved. Dr. Saidul Islam, sir, thank you so much for coming to our college. And I request all of you to please give him a standing ovation. It is not on a single day that you have Dr. Saidul Islam visiting an institution, and we are indeed honored with his presence today. Along with him, my dear brother, Dr. Asif Ahmed, who has tirelessly lifted up the profession of prosthodontics and crown and bridge in Tata Memorial Hospital in Kolkata. I had the privilege of first meeting Dr. P. Arun, the director over there, and then I came to know Dr. Asif's level of work. He was tirelessly trying to rehabilitate the cancer patients who were attending Tata Medical Hospital. They didn't have a very full-fledged oncology unit at that point of time, but sheer efforts of Dr. Asif has led to a very, very functional prosthodontic unit, and we are extremely proud to have such a great center in Kolkata, where rehabilitation of oral cancer patients are being done regularly. Thank you, Dr. Asif, also for coming and visiting the college. I briefed my managing director, sir, Mr. Taranjit Singh, sir, who was equally enthusiastic about Dr. Saidul Islam's presence in our institution. And both of you would be very happy to note that we are also proud of our performance of our students. Dr. Nandini Changothia, who has topped the INICET examination from this very college, and we are extremely proud for her achievements, along with the achievements of all the MDS NEET entrance examination toppers. I think she is also the 7th rank holder from Kolkata in NEET MDS, along with rank number 24 belongs to this institution, and a few others are also there who are amongst the top 500. And as per the instructions of Taranjit Singh sir and our director, we would be arranging another felicitation ceremony separately for our students who have brought such glory to the institution. So not wasting much more time, I think it is an enriching program for the day. Anyone who has interest in oral surgery, please have a look to what oral surgeons can achieve if you have the knack and if you have the ambition. And along with that, the rehabilitation program which will be shown by Dr. Asif Ahmed. So I hope that this enables all our students to take up research projects, to take up publication as something which you would like to do. And we are going to hold this conference every year. We are trying our level best to inculcate the spirit of research amongst the students so that you can come up with good publications which ultimately boosts your career in your ultimate growth in dentistry. Thank you so much.
Sir, we are honored to have your presence and guidance with us today. Thank you so much, sir, for your inspiring and encouraging words. Without further delay, we would now like to commence today's session by warmly welcoming the chairperson of the first session and joint organizing secretary of the event, Dr. Sudip Chakraborty, sir, Professor, Department of Oral and Maxillofacial Surgery. With that, I would like to request, sir, to introduce our first speaker of the day, Dr. Shoidul Islam, sir, and invite him on stage.
Hello. Good morning, delegates. Good morning, dignitaries. Good morning, faculties, and good morning, students. Who needs an introduction when the name is Dr. Sheikh Shoidul Islam? He is the pioneer of microvascular. And he has delivered keynote speakers, and I remember one prestigious Genewala oration in different conferences, not only conferences related to maxillofacial surgery, but also related to head neck surgery, ENT surgery, plastic surgery, etc., reconstructive surgery, World Reconstructive Association, Indian Reconstructive Associations, etc. And he also held different workshops in different parts of the countries, and including our Chittaranjan Cancer Hospital in Kolkata, Apollo Clinicals Hospital in Kolkata. So now, sir, this podium is now yours. Dr. Sheikh Shoidul Islam, please come.
With that, I would also like to request the Director of Research and Development, GNI DSR, Dr. Pramod John, sir, along with our Principal, sir, to kindly felicitate our first speaker of the day with Uttariya bouquet and a memento. Thank you, sir, for the gracious felicitation. Dr. Shoidul Islam, sir, the stage is yours.
Hello. Very good morning. Thank you, Professor Jayanta Bhattacharya, for inviting me for Speak 2025, Reconstruct 360, complete rehabilitation of oral and maxillofacial region. Thank you very much for inviting me here to share my experience that I have gathered over the period of past 40 years. I'll be talking on reconstruction of the cancer defect, post-ablative defect. We all know that the oral cancer burden is very high in our country. Practically, oral cancer is an Indian disease. The incidence is very, very high because of, you all know that so many oral bad habits, use of tobacco, etc. And we all know that there are several modalities to manage these aggressive disease: surgery, radiotherapy, chemotherapy. But surgery lies the mainstay to control oral cancer. Today we will be talking about rehabilitation of oral cancer victim. This scenario no more acceptable today. It's a scenario of past. The patient free from disease, cured from oral cancer. But they are all of them are a psychiatric patient because of such facial deformities, not presentable to the society. So you need to think not only to cure the disease, but how to improve the quality of life. And quality of life is synonymous to reconstruction. We need to reconstruct the part that nature has given to the victim, but fortune has taken away. The main goal of reconstruction of post-ablative defect, definitely maintenance of oral continence, that should facilitate swallowing, that should prevent aspiration, that should try to preserve speech, that should be able to protect vital structures, restore sensation, and definitely that should try to achieve primary wound healing, because most of the patient needs to be sent to the other department for adjuvant therapy, that is radiation therapy, chemotherapy, because most of the patients come to us in advanced stage, stage 3 and 4, which requires multimodality treatment, combined surgery combined with radiotherapy and chemotherapy. And definitely possible to obtain cosmesis and ablative cure. What's that? Ablative cure. I'll come to this point later on. The history of reconstruction of the head and neck region or the maxillofacial region dates back to 600 BC, the time of Susruta. Is considered to be the first maxillofacial reconstructive surgeon of the world. Just think about that era where there was no general anesthesia, no antibiotics, where some victims, their nose has been chopped away. But he used to reconstruct those facial defects with a forehead flap. That is till date very much popular. for reconstruction of facial, various types of facial defect. Now, I will be talking on the latest advancement or recent latest technology, that is the microvascular. What's that? Before coming to that, I like to say that we have some local and regional flaps. Local flaps, a flap or a tissue, block of tissue taken adjacent to the defect, taken from the area that is very much adjacent. So this is the defect and this tissue is simply advanced. This is a forehead flap. The technique that was introduced to the history of maxillofacial reconstruction, not today, 600 years before Christ, Vichy, by Susruta, the forehead flap for nasal reconstruction. And some other flaps is the pectoralis major myocarditis flap, that is considered as the workhorse flap, deltopectoral flap, DP flap. I am not going to talk anything about that. It is not unusual to see a very advanced disease like this in our country. In many situations, if that disease is operable, yes, such a very advanced disease, most of the time it is inoperable. But if it is considered operable, if you are able to achieve R0 on the table, if you are able to achieve a free margin free resection, that is possible. Such T4B and stage 4, stage 4A, 4B, in 4B previously was considered inoperable. Now, not all cases, but most of the T4 disease considered operable. That depends on some factors, whether infranose or supranose disease. I am not going to that, the resectability issue, but what I want to say, the such type of advanced disease, if considered inoperable, but because of lack of facilities to address such a defect, that will be left behind following ablation. We are not able to address the defect, we are not able to have adequate tissue to reconstruct such defect. But now it is possible. Consider this. Am I fine? I'm audible? Okay. The mid-third or almost one half of the face has been chopped away or just taken away for cancer ablative procedure, for cancer resection to achieve disease-free margin. Here the maxilla, floor of the orbit has been removed, the periorbital fat is hanging. So you need to provide some support to prevent herniation of this periorbital fat that may lead to severe diplopia. And also to provide, we need to provide adequate tissue for reconstruction of the palate, oral mucosa, and at least outer skin covering if bone is need not to be provided. But if you can provide the bone also, we can achieve excellent reconstruction. Here also, one half of the face has been removed. A defect of mandible and associated soft tissue defect also, but the defect spanning from one angle to another angle. The central part of the mandible is going to be absent or absent here, resected. We all know the importance of the central part of the mandible. The genial tubercle that gives attachment to the genioglossus muscle, the safety muscle of the tongue. So if the genial tubercle or the attachment of the tongue is not provided adequately, tongue will fall back. That will lead to severe respiratory complication, respiratory distress. So patient need to be on tracheostomy for a very prolonged period. So previously what we observed 40 years back, When a patient used to come to the oncology department with cancer involving the central part of the mandible, just because of lack of facilities to address reconstruction of the central part of the mandible, the patient was simply referred to department of radiation and chemotherapy department just for palliative treatment because of T4 lesion. When the disease involves the mandible, simply becomes T4 lesion, stage 4 disease. You can't cure it without surgery. It needs a multimodality treatment, surgery followed by radiation therapy, chemotherapy in some cases, not in all cases. So definitely, if we try to cure or if we try to treat such disease with radiation only or combined radio chemo, we can't achieve cure. But previously, patient was forcibly sent to department of radiation therapy and chemotherapy only because of lack of facilities. What facilities? To address or to reconstruct the central part of the mandible. So this is an absolute indication for reconstruction mandible, and this reconstruction can't simply be achieved without a microvascular reconstruction. Why? We can simply many times try to achieve a mandibular continuity with a reconstruction plate. If the disease is a benign one, absolutely fine, it will tolerate. The patient or the tissue will tolerate the reconstruction. It will be there, definitely. It will be able to maintain the contour. But coming to oral cancer, as I said, the patient needs surgery followed by radiotherapy. Following radiotherapy, the tissue condition becomes so bad that it is not able to tolerate the minimal pressure created by this reconstruction plate, and the fate of the reconstruction is simply exposure. The plate will undergo exposure, so plate needs to be addressed. But therefore, reconstruction plate is never an answer for cancer patient. Maybe answer for benign lesion like ameloblastoma, ossifying some other things. Not only that, sometimes the reconstruction plate undergo fracture also like this. Young girl, okay, I'll mainly talk on the oral cancer defect, but for the sake of discussion, I'll cover some benign disease. This young girl, she had simply ameloblastoma of the jaw, and jawbone was reconstructed with a free iliac crest bone graft. The fate of the bone graft, first of all, it will undergo resorption, but it will stay definitely. Previously, we had done lots of reconstruction with iliac crest and we achieved acceptable result. The problem lies with infection. If any part of the bone graft get exposed or get infected, the fate of the graft is simply removal. You cannot control infection because this is simply a dead bone. That iliac crest bone graft works as a scaffold only. It will undergo resorption and the new bone will be formed. But for the time being, for total resorption and deposition or reformation of bone, it takes time, and for that time period, the area should be completely free from infection. But infection arises before that time period, you simply need to lose the bone graft. So ultimately this happened to this girl. Because infection, the bone graft lost. Only 22 years old. Now consider her fate, especially for our country. What about, you all know what I want to mean. So we need to address or we need to reconstruct. So once the free bone graft fell, the same only and only option is a free flap, the microvascular reconstruction. A disease, central giant cell tumor. You can appreciate the multi-local radiolucency arising from the condyle of this side, left side, coming to the condyle coronary artery of the other side. So entire mandible is involved with the disease. See, if you try to cure it, so the complete disease needs to be removed. She underwent surgery, conservative surgery, almost 10, 11 times before coming to us. But every time we record, because complete removal was not possible. Why it was not possible? Because that will simply leave behind a total mandibular defect, spanning from one condyle to another condyle. And without a microvascular flap availability, simply it is impossible to reconstruct such a defect. This young girl, I operated on her in 1998. I started microvascular surgery in 1997, and this girl I operated in 1998. Before coming to me, at the age of 19 years, she was underwent almost 14 surgeries by all the eminent hospitals, state hospitals, government hospitals in our country, in our city. This is not an fibrous dysplasia, not a case of cherubism, but it's a oma, ossifying fibroma, tumor. When it is an oma and a tumor, if it is a fibrous dysplasia, you can do cosmetics. You all know the management. I am not going to talk about any management of fibrous dysplasia, but I want to give importance or stress on this fact that is a tumor, so it needs to be removed completely. But look at the radiology of this patient. Is the anterior cranial fossa floor. This is a tumor involving the cranial floor. Entire facial skeleton, entire maxilla, mandible involved. So if it is oma, yes, it was oma, ossifying fibroma, tumor. So to cure it, you need to remove the diseased part. It means total maxillofacial skeleton, the total mandible, maxilla, also the cranial base through the craniofacial resection. Yes, good surgeons were definitely available to go for surgery that time. But following such aggressive removal of the entire facial skeleton, the defect that would be there, how to address that? When she came to me first time, she was at a point of respiratory distress. The whole face, the oral cavity was full of tumor. And practically there's no space for breathing. Nose, yes, nose was also blocked. So I had to do an emergency tracheostomy for this patient before doing the actual surgery. I will come to this patient later on. Now, let us consider how do we address post-ablative defect. The victim of oral cancer at the carcinoma of the buccal mucosa, a composite resection has been done. So there is a defect of the face. So at least we need to provide two elements to cover this defect. One for the oral lining and one for the outer covering, skin covering or outer covering. So use flap. For a conventional technique where the microvascular facilities not available, we need to go with a pectoralis major magnetis flap, and this is a deltopectoral flap. Pectoralis major magnetis flap will go inside the oral cavity to provide the lining for the defect, and the DP flap that will provide the outer covering. Sometimes it is possible to reconstruct with a single PMMC flap, but that needs a huge cutaneous pedal, and many times what happens, part of the skin petals undergo necrosis many times. So that's the patients with buccal means the carcinoma and fungating of the submandibular region, and this part of the facial skin is also involved. So we need a three-dimensional oncological clearance. So a simple segmental mandibulectomy or hemimandibulectomy and composite resection means excision of the outer skin and oral mucosa has been done. And definitely there is a huge defect in this region. So in a conventional technique, what we do, we take two regional flaps, the regional flaps. This is a PMMC flap, pectoralis major myocutaneous flap, and this one is the DP or the deltopectoral flap. One for the lining, one for the covering. But patient needs to be taken to the operation theatre again after 3 weeks for detachment of this DP flap. So it is, in most of the situation, it is a two-stage procedure. Now, let us look at this problem in more advanced way. Instead of going in two-stage procedure like this, a similar but more advanced disease. And this is the outline, this black marking is the outline for inclusion of the healthy disease-free margin. And that will simply lead to such a huge defect. And this is the surgical specimen following ablation. So in a conventional technique, we will have to go with a flap from the chest wall, a pectoralis major and DP. But if you can take a flap which is taken from a distant part of the body and the flap vascular pedicle completely detached, we can address it in a single shot like this. So this is a flap or cutaneous element with underlying muscle, some sort, little bit of muscle fiber. But here this is the vascular pedicle of the flap. This is the donor site. From this area, the flap has been harvested, but the vascular pedicle completely detached. So it is free from its donor site. So we can call it a free flap. Flap now transferred to the surgical defect, a huge skin. It is not a skin graft, a thin layer of skin. That skin graft will survive without any provision of blood supply. That will simply undergo, or that will take nutrition by plasmatic imbibition, etc. So many procedures say that, physiology is there. buy this from the nearby shop. I need to go from far away to import it. Is something like that. You are not able to achieve or take adequate tissue of adequate quality, quantity and element also. You need to import it from some other part of the body. It's something like that. So we need to do two techniques, two important parts for reconstruction. One is to import a tissue, adequate tissue from the appropriate area of the body. What type of tissue? That will depend what type of tissue you need. Only skin, skin and muscle, skin, muscle plus bone is okay. Depending on that, you choose a particular area of the body where from you are taking the tissue. So that is one part, harvesting the tissue or a donor site. Simply a donor site from where you are going to, harvest the tissue. And the second thing, you need to join the blood supply, establish the blood supply. That is the anastomosis. So two important aspects is there. One is very delicate handling of the tissue under operating microscope, that is anastomosis, and you must have the adequate surgical capability to harvest tissue from a distant part of the body. So these two things is very important for microvascular reconstruction. So what we have seen for a conservative treatment, conventional reconstruction, we had only few tissue available to us, a regional tissue from the forehead flap, DTP flap,